The last presentation is evaluating neutrophil-to-lymphocyte ratio as a predictive tool for post-operative outcomes in patients undergoing open lower extremity revascularization procedures by Lily Adler and colleagues from Rutgers Robert Wood Johnson Medical School.
All right, good morning, everyone. Thank you so much for the opportunity to speak with you today. My name is Lily Adler, and I'm a second-year medical student at Rutgers Robert Wood Johnson. It's really exciting to be here. So we conducted a study looking at neutrophil-to-lymphocyte ratio as a predictive tool for post-operative outcomes in patients undergoing open lower extremity revascularization procedures. So just to give some background that everyone here I'm sure knows, roughly 6.5 million people over the age of 40 have peripheral arterial disease in the United States. And neutrophil-to-lymphocyte ratio is a readily accessible, low-cost marker of systemic inflammation. And previously, NLR has been shown to be clinically useful for predicting patient outcomes in a variety of diseases and procedures, most notably including COVID-19, and then specific to vascular surgery, carotid endarterectomies, and EVAR procedures. So going into that a little bit more, a previous study by King et al. Showed that neutrophil-to-lymphocyte ratio might be useful for determining which patients should undergo medical treatment and which patients should undergo carotid endarterectomies in asymptomatic patients with carotid stenosis. And so they found that a cutoff point of 3.0 was clinically significant. So if you had a high NLR, meaning above 3, you did better with medical therapy. And if you had an NLR below 3, then you did better with a carotid endarterectomy. In another study that came out recently, neutrophil-to-lymphocyte ratio was associated with adverse events after EVAR procedures. So this study looked at 777 patients undergoing EVAR. They found a maximal NLR cutoff point of 3.6, and they found that NLR was an independent predictor of 5-year mortality, as well as reinterventions at 30 days, 1 year, and 5 years. So our goal was to look at neutrophil-to-lymphocyte ratio as a predictive tool in patients undergoing open lower extremity revascularization procedures, and as part of that to determine the maximal NLR cutoff point for that population. And just as a reminder, here's a neutrophil and a lymphocyte in the upper right-hand corner. So we conducted a retrospective study of a prospectively maintained database of patients who underwent open lower extremity revascularization procedures at Robert Wood Johnson University Hospital from January 2011 until January 2013, with a patient size of 179 patients. So our preoperative NLR was calculated within 6 months of the procedure, and if there were multiple data points available, we took the data point from the date closest to surgery. Our primary outcomes were major adverse limb event and death, and our maximal cutoff point was calculated using the maximally ranked statistic method. So our results showed a maximal cutoff point of 4.9. So it's important to note here that there are no standardized values for a neutrophil-to-lymphocyte ratio. So there are studies that suggest that a normal NLR is roughly 1 to 3, an NLR of 6 to 9 suggests mild stress, while critically ill patients may have an NLR of 9 or higher. And occasionally these can even reach a value of 100. But because there's no established value, it's really important that we set what the cutoff point should be for these various patient populations. So when comparing our low NLR group, meaning less than 4.9, to our high NLR group, meaning above 4.9, we found no statistical significance in any of the demographic factors of these groups. So there was no difference in gender, age, race, BMI, smoking, diabetes, hypertension, hyperlipidemia, or recent infection. And similarly, there was no statistical difference in the procedures that each group underwent. There was no difference in the case class or in the preoperative Rutherford classification. So overall, the median NLR for our patient population was 3.1. And when we controlled for multiple comorbidities, including gender, age, smoking, BMI, diabetes, hyperlipidemia, and hypertension, our analysis showed that NLR was an independent predictor of mortality, but not for major adverse limb event. And so here's a Kaplan-Meier curve showing the difference in survival, stratifying the population by the cutoff point of 4.9 for the NLR. And you can see that there was a significant difference in survival. Similarly, there was also a significant difference in major adverse limb event, though it's important to remember that when controlling for multiple variables, we found that NLR was not an independent predictor of major adverse limb event, so just an important note there. So the limitations of our study are that this was a small subset of patients. We were limited by the retrospective nature of the research. Obviously, it would be much better if we could have an NLR value taken right at the time of surgery, but that's not possible given this study design. We were limited by the time at which blood was drawn. And again, NLR is only a surrogate marker for inflammation. It doesn't actually explain what is going on in the individual patient, and so it may not be the most useful in determining the best way to address this in a particular patient. So our results suggest that our study results suggest that NLR is an independent marker of surgical risk. So going forward, what we plan to do is to expand this study to include more patients and to investigate whether it is possible to lower NLR preoperatively and whether doing so would improve patient outcomes. So thank you so much, and I'm happy to take any questions.
Thank you for that presentation. We looked at NLR in amputation patients a few years ago, and we found that it did correlate with mortality following amputations. But I always sort of wondered what we should do with that data, because NLR, like you said, is an inflammatory marker. It's just a marker of other things going on in the patient. And other than just assessing surgical risk, there's not a whole lot we can do. Do you think that actually decreasing the NLR, and how would, because you mentioned that in your slide, how would you decrease somebody's NLR?
Yeah, so I actually have a slide on that if we can pull them back up. It's a great question. I think it's important to kind of understand, here we can, So I think one of the ways is that you can try to treat the underlying cause of the inflammation, so that if there's an infection, you can try to address that. Diet and exercise, obviously if a patient is about to have an intervention for lower limb ischemia, then exercise might not be the most reasonable intervention there. But there are some preliminary studies that I've looked at that suggest that vitamin C supplementation or vitamin D supplementation during the time of surgery might actually be helpful, but the data is really limited. I don't think that's a cure-all by any means, but I think if it could improve patient outcomes at all, then it's worth potentially looking into. I also think that one of the things that we found in subsequent data analysis that we've done since the time that I submitted this is we've looked actually and found that age might be a better predictor than NLR of patient outcomes, which makes sense. So what we did was we stratified by age, and we found that younger patients under 80, it might actually be useful for stratifying risk in those patients. And I think it might help to give a patient an accurate understanding of kind of what the post-op outcomes might be. And I think giving patients a fair understanding of what their surgical risk is a value in and of itself.
Hi, great presentation. Did you look at statin dose? Because maybe that's the way you can lower your neutrophil-to-lymphocyte. Like maybe the people with high dose, they're not on high dose statins, and that you can change. And the other one is, did you look at cause of death? Is it MIs? Patients died from MIs.
Yeah, we've been collecting all that data. I didn't have a chance to analyze kind of all of that, and this patient population is also really small, but as we expand to a larger patient set, we're hoping to look at many more variables, including the statin dose and cause of death.
Thank you.
Yep, thank you.
Great. Yeah, thank you. My partner, Jay Cho, and a research fellow, Alex King, have been looking at this for a number of years, and they looked at it in the carotid paper you mentioned, aortic, and just recently in 500 patients that underwent FEMPOP intervention. And what's amazing is if you look at below 3 to 4, and over 4 NLR ratios, you get a stepwise increase in 30-day mortality. And that predictive model is as good as any other biomarker that's currently studied. So I applaud you for looking at this. I think this is going to be really fascinating going forward to see if we can modulate how to get this lower and improve outcomes. Thank you.
Thank you.
Hi, good morning. Very nice presentation. I'm Jeannie Ruddy from the Medical University of South Carolina. I was curious, you commented that your median NLR was 3.1, but your threshold value had been selected at 4.9. Can you comment a little bit about how you identified that threshold?
Yeah, so we used the maximally ranked statistic method to find the point at which you would find the maximal difference between two groups. So if you pick 4.9, then that's the point at which you get the greatest difference between the two groups. This value was higher than other procedures, and I think that might be related to the fact that I think patients undergoing these lower limb procedures tend to be sicker. So our value is 4.9, and the other studies that I mentioned and that were just referenced was in the range of 3, so 3 and 3.6.
Thank you very much.
Thank you.
So this concludes our session this morning. As a reminder, there are tickets available for the presidential dinner tomorrow night, so if you haven't gotten tickets and you're interested in going, stop by the registration table. At 9:30, we will be having an interesting case session here with Mark Conrad, and otherwise enjoy the slopes, and we'll see you this afternoon.